A very good morning to one and all. I'm Dr. Sidra Ansari, and in this session, I'm going to talk about orthognathic surgery. Last time we discussed about the treatment planning that was required for an orthognathic surgery. Today we'll see the osteotomy procedures that are done in orthognathic surgery. Now, before we go on to the details, you need to know that in orthognathic surgery, the jawbone are intentionally sectioned at various sites to correct the dentofacial deformity and to reposition the sectioned bone into a desired position. There are two terminologies that you need to know. One is osteotomy, the other is ostectomy. Osteotomy is nothing but just simple splitting up of the bone is known as osteotomy, whereas ostectomy is removal of a part of a bone. Before we go on to the detail of the procedure, you need to know the biological basis on which orthognathic surgery is started. Bell did an extensive research on rhesus monkey to see the revascularization and bone healing that occur after osteotomy. He found that whenever an osteotomy segment is pedicle at least over one of the vascular supply, the surgical procedure is well maintained, the vascularity is not affected. He also finds that when you're doing a maxillary osteotomy or complete round fracture of the maxilla, and if you keep the palatal pedicle as well as the labial gingivobuccal pedicle secured, the healing is not hampered. After the osteotomy procedure, the vascularization is not hampered. Similarly, he also stated that mandible is supplied by two types of blood supply. One is through the inferior alveolar artery. It gives a centripetal supply because it supplies the bone from inside to outside, whereas the periosteum supply the mandible from outside to inside, that is the centripetal type of flow. When any one of the flow is hampered, the other one takes over. This is the reason why we could do a mandibular osteotomy procedure, because compared to the maxilla, mandible is a lot of cancellous bone is there. The bone is more dense. But still, since because of this vascular supply, you can do a variety number of osteotomical procedures and still maintain the vascularity of the osteotomy segment. Now, let's move on to the mandibular osteotomy procedures. Now, mandibular osteotomy procedures are basically divided into body osteotomy and ramus osteotomy. Body osteotomy procedures include anterior body osteotomy, posterior body osteotomy, segmental cervical mandibular osteotomy, genioplasty. Whereas ramus osteotomies include vertical ramus osteotomy and intraoral modified sagittal split osteotomy. Now, before you see these procedures, you have to do an orthodontic treatment before you start with your orthognathic surgery. It's always a combination of oral surgery and orthodontics. Now, in your orthodontics, what you do is you correct any minor discrepancy that is present in your dental arch. You align the arch, you decompensate the arch. You correct the curve of CSP with the orthodontic treatment, whatever you can. Okay, so you can do all your dentoalveolar treatment, correction, that is decompensation, before the orthognathic surgery. Then you prepare a splint. Now, splint are of two types, intermediate splint and the final splint. Intermediate splint is one that is used in between the surgery before you do the final positioning, and as the name suggests, final splint is the last splint that you put into the patient mouth, put the osteotomized segment and do a maxillomandibular fixation. So these are very important steps that are required before orthognathic surgery before you proceed to it, because these are certain terminologies that I'll be using as I go forward. Now, let's begin with the mandibular anterior body osteotomy. Now, indication for this procedure is that when there is mandibular prognathism, but there is functional posterior occlusion, that is posterior teeth is proper occlusion, so you need not have to touch it. That's the reason why you touch only the anterior part of it. Or in case of class 3 malocclusion with or without anterior open bite, where posterior teeth cross bite could be corrected orthodontically. You do not require an orthognathic surgery to correct the posterior crossbite. You can simply do it by decompensation and alignment with orthodontics. So these are the indication of anterior body osteotomy. Now, what is the exact procedure in that? In anterior body osteotomy, you will give a vestibular incision bilaterally in the premolar, first and second premolar, and if you need a better access, you can extend your incision towards the molar. Now, basically it is said that whenever you're doing an osteotomy, you will involve a tooth anterior and posterior to the osteotomy cut. Now, most of the time what happens is we do extraction of either first and second premolar depending upon the requirement, and we do the osteotomical cut through these extraction socket. Most of the time we do this, but in few cases when we are correcting the curve of SPE, in that cases we might have to do an interdental cut. That means between the two teeth, which is very rare. When you do not want to remove a tooth, in that case you can do the cut between the two teeth. In that case you cannot use a burr. You have to use a very fine saw because you do not want to affect the periodontal ligament. Okay. Now, since as I mentioned, most of the time we have to do the extraction, so I'm going to describe that procedure. So once you have done your extraction of either first or second premolar, depending upon the patient requirement, okay, you will make an incision bilaterally from the first premolar and if required extend it to the first molar region. You will do subperiosteal dissection both superiorly as well as inferiorly. Okay. Then at the same time, through the extraction socket, you will do lingual dissection. You'll put a periosteum on the lingual aspect. You will try to separate the lingual mucosa and put a periosteal elevator on the lingual side so that the lingual nerve is protected when you do your osteotomy cut. So once your periosteum is reflected, you will start with your osteotomy cut. Okay, through the extraction socket from above downward. You will cut both the cortex, buccal and lingual cortex, till inferiorly. Keep in mind that the mental nerve exits through between the first and second premolar. So you have to be careful, try to preserve the mental nerve and make your osteotomy cut either anterior or posterior to it. You could modify this by making a step in your cut. Rather than making a straight cut, you can make a step. In that way, you can preserve your mental nerve which exits through the mental foramen. Okay, you will complete your cut from both buccal and lingual cortex, both start from superiorly to the inferiorly. Okay, once you have done this, remove any kind of bony inherence, then put a splint on the maxilla and this mobilize this segment, fix it into the splint. That will determine your final position and then fix it. The dental segment is fixed in the maxillomandibular fixation, whereas the inferior portion you could put a mini plate. Two holes on either side of the osteotomy segment. The similar thing is done on the opposite side and you do the final fixation. The wound is always closed in layers and a pressure dressing is given. Now, posterior body osteotomy. Now, indication for posterior body osteotomy is when posterior teeth is missing in skeletal class 3 patient. Sometimes the posterior teeth are missing, so rather than extracting a premolar and then doing this procedure, why not utilize that space? Or sometimes the posterior cross bite or there is lingual inclination of posterior segment. In that cases, you will offer posterior body osteotomy. But this is very rarely done because of the technical difficulty and there are high chances that you might injure the neurovascular bundle, inferior neurovascular bundle. So in this procedure, what you will do is, you will give a vestibular incision in the posterior part of the mandible. Okay, that is on either side of the osteotomy segment, like from the first premolar to the third molar you can do. You can extend it depending upon your requirement. You can also extend it along the external oblique to the anterior part of the ramus, depending upon the exposure you want. Once you have given the incision, do subperiosteal dissection, both superiorly, inferiorly, put a channel retractor inferiorly so that the inferior border is thoroughly exposed. Now, once you have done through that extraction socket or an edentulous space, you will start your osteotomy cut. Okay, you will complete the superior cut, both buccally and lingually, just above the inferior alveolar canal. Okay, when you come close to the inferior alveolar canal, you will do just the buccal cortical cut. Try to shave the bone buccally till you see the canal. Take a nerve hook, move the canal superiorly, or you can say buccally, so that you can complete the lingual cut. Once you have done that, with the nerve hook, lift the nerve superiorly and complete your inferior cut. So you will start from superiorly, just stop above the canal, do a buccal window, move the canal, do your lingual, complete your lingual cortical cut and then lift the canal up and then complete your inferior cut. Once you have done this, then you will reposition accordingly. As I mentioned earlier, depending upon your requirement, you can either give a step or you can have a straight cut also. Either you want to advance or you want to move behind, you could do both of the things. And you can arrange the curve of SPE also if you want with this. Then once you have done this, put the splint in the maxilla, then do maxillomandibular fixation around that. Then you put a mini plate at the inferior border, close the wound in layers, put a pressure dressing. Now, indication of subapical mandibular osteotomy. Now first is when you want to correct mandibular dentoalveolar proclination. In that case, you could do segmental subapical osteotomy. Or where you want to close a mild anterior open bite, you want to level the accentuated curve of SPE, or to correct the mandibular arch asymmetry. Now this procedure can be done individually also or in combination also. Combination as in you could do maxillary subapical osteotomy to correct bimax protrusion. Okay, so either individually or in combination. So now what exactly you will do in this procedure? You will give a vestibular incision from canine to canine region, and you will completely deglove the symphysis region. Now when you're giving a vestibular incision, you have to keep the attached gingiva intact. You will give the incision from the mucogingival junction, okay, extending from the canine to canine region. And then you will always have an extraction socket, either in the premolar or molar region depending upon the requirement. You have thoroughly degloved it. Okay, through the extraction socket, you will do subperiosteal dissection of the alveolar area. Once you have done this, you will try to separate the lingual mucosa from the extraction socket, okay, to protect the lingual nerve. Once you have done this, you will take your vertical cut. Okay, from both the sides, you will make your vertical cut in the extraction socket, both buccally and lingually. Once you have completed your vertical cut, then you will join the two vertical cut with a horizontal cut. Now this horizontal cut is 5 mm below the apices to prevent any kind of nerve damage to the tooth. So 5 mm below the apices, you will measure below the apices of the canine, because canine has the longest root compared to the other. Then you will join this horizontal cut. It should be both buccally as well as you keep the lingual cortex intact. Then with your fracture, just green stick fracture. Here the vascularity is basically from the lingual mucosa and periosteum. Okay. So once you have done this, put a splint into the maxilla, fix the teeth in that splint, maxillomandibular fixation, and then you can plate the segment in the proper position that you have got. Close this thing, and since we have degloved it, you have to close in layer. Now, degloving incision in these cases has been modified, because what happened when you cut, there is fibrosis, so vestibular depth decreases. So people have modified this incision. They said when you're giving an incision, be more towards the lip. Start from the lip and go tangent to the bone, so that you are preserving the mucosa, maintaining the vestibular depth. Or you could give a modified Crown's incision, which is a W-shaped incision, so that you maintain the vestibular depth in the anterior region. Now, let's move on to the genioplasty procedure. Any deformity in the chin has to be addressed in 3 planes, that is anterior-posterior, vertical as well as transverse. Thus, genioplasty can be done either to augment, to reduce, to straighten, or to lengthen the chin. Now, in case of augmentation genioplasty, you could do a sliding horizontal osteotomy of the symphysis region, or you could use an autograft to augment, or an alloplastic material like silicone or hydroxyapatite. Now, in case of augmentation genioplasty, as I mentioned earlier, you have to give a degloving incision from canine to canine region. Either you will have a vestibular incision, the incision more towards the lip, or you will give a Crown's incision, which is a W-shaped incision. Once you have done this, you do complete mucoperiosteal elevation, deglove the chin. You have to strip off the digastric muscle, and sometimes you might have to score the periosteum, because scoring will help you to close it once you have augmented the chin. Because when you're augmenting, you're adding bone to it, so you need soft tissue coverage over it. For that, you need to score the periosteum. So you can do it at this time only when you're degloving it. Deglove it, do muscle dissection of the digastric muscle, score the periosteum. Okay. Now once you have done this, you mark the area, that is your osteotomy cut should be 5 mm below the apices of the tooth. Now keep in mind that most of the time the anterior-posterior dimension of the chin is around 8 to 12 millimeters. So this much amount of augmentation or advancement you can do. So depending upon the need, you slide the bone anteriorly, put in the anterior position and try to fix it. Now fixation can be done either by screws you can fix, you can use plates. Now plates are also different type of plates are available. Y-shaped plates, Z-shaped plates are available, or you have a specific X-shaped plate for plating the chin that is available. You fix the chin in the proper position. Once that is done, any kind of bony hindrance or bony prominence, try to trim it off and then close the wound in layers. Once you have closed the wound in layers, put a pressure dressing. On the below below your lower lip and the chin. The pressure dressing should not be on the chin, but when you're trying to put a Dynaplast, cut an oval shape between it so that this gap remains empty. Your pressure dressing comes here and the side area, but not on the chin. You're doing genioplasty. Okay, then in reduction genioplasty. Reduction genioplasty, you could either reduce it in transverse dimension, anterior-posterior dimension, or vertical dimension. When you have to reduce it in anterior-posterior dimension, you will make a horizontal osteotomy cut and slide it behind so that you reduce the anterior-posterior dimension. And when you're sliding it behind, the excess part of the bone, you can feel it behind, so you need to trim that excess part of bone. Or when you want to reduce it vertically, you will make two osteotomy cut. The first superior cut, then first you will make an inferior cut, then you will make a superior cut. Then the wedge of the bone that is present, you will remove it, and then you will mobilize this inferior portion of the chin upwards and fix it. And then the same thing, you close in layers and put a pressure dressing. Now let's move on to the mandibular ramus osteotomy procedures. Now in 1954, Cardwell was the first one who proposed the subcondylar vertical osteotomy. Now indication of this procedure was when you want to do a mandibular setback of more than 10 millimeters. And when you want to do an asymmetrical setback of mandible, you can opt for this procedure. Now in this procedure has to be done extraorally. You could either give a post-ramal excision or submandibular excision to gain access to the ramus. So once you give an incision of around 2 to 3 centimeter, you can extend it to 4 centimeter, skin incision, subcutaneous tissue. Then you try to platysma, try to dissect the submasseteric sling to a complete subperiosteal dissection so that you expose the ramus completely. You should be able to see the inferior border, the angle, the posterior border of the ramus, as well as you have to see the sigmoid notch. Because here the osteotomy cut start from the sigmoid notch and to the inferior border just anterior to the angle. Now, how will you preserve the neurovascular bundle? Because you are stripping so much on the lateral side, you need not strip on the medial side too much because you want to preserve the vascularity. So how will you preserve the neurovascular bundle? We're all aware that on the medial aspect, okay, when the mandibular inferior alveolar foramen, you have a lingula. Okay, the similar counterpart of lingula, you will have a bulge on the lateral aspect of the ramus of the mandible. That bulge is called as Rehrmann's bulge, okay, or Rehrmann's bump. So you have to put your osteotomy cut posterior to this bump so that you avoid injury to your neurovascular bundle. Now, once you have identified that, you will mark your osteotomy line. Okay, once you have marked this, you will start your osteotomy cut from the sigmoid notch till the Rehrmann's bump. Okay, both start from the labial aspect and go medially. Put a retractor on the medial aspect so you do not injure the medial soft tissue. Then once you have completed this, start the cut now from the inferior towards the lingula. Now why do we do this? While doing this, if by any chance your inferior alveolar artery get injured, you could easily separate the fragment and you can ligate that artery. That's the reason why we start from superiorly from the sigmoid to the Rehrmann bump. Then we start from the inferior aspect to the Rehrmann bumps and then separate it. So once you have done your osteotomy cut, you can separate the segment through an osteotome and then accordingly you can mobilize the segment. You can do the same procedure on the opposite side. So you have two fragments, a medial proximal fragment and a distal fragment. So your neurovascular bundle and your teeth are present on the distal fragment while your condyle and the posterior part is attached to the proximal segment. Now when you have to do a setback, okay, your proximal segment will overlap your distal segment. So you have to decorticate. Now where will you decorticate? You will decorticate on the lateral aspect of the distal segment and the medial aspect of the proximal segment. Once you have done the decortication, you will have an adequate contact of the bone, then you plate it. Now before you plate it, you have to fix the mandible to the maxilla by intermaxillary fixation. So here splint come into the picture. You put your final splint, you reposition the teeth in the proper position and then you fix your osteotomy segment. You will close the wound in layers and you will suture it. Now a modification of this is a C-shape osteotomy. Now in this C-shape osteotomy, you not have to completely strip the periosteum from the ramus. because here the osteotomy cut do not start from the sigmoid knot but inferior to it. At least you can say the cut, it has a horizontal cut which is 2 to 3 mm above the lingula. So you will have a horizontal cut above the lingula, okay, just posterior to the lingula. Then you have a vertical cut down. Either this cut could extend directly till the inferior border, or it could extend obliquely on the, you can say, lateral or the buccal cortical plate, as you can see in the photograph, which is a modification. Now in this case you can do advancement also. When you're planning for advancement, you can put a bone block between that if you want to do an advancement. Now the advantage of subzygomatic vertical and oblique osteotomy is there is an adequate direct access. There is adequate control of the bony fragment, good surface contact between the bony fragment, minimal relapse. Okay, if you want to do a gonial angle contouring, you could do that. Then there is no loss of teeth or arch size, since you do not have to extract a tooth or do not have to go through the arch. You are doing all the procedure on the ramus, that is the posterior aspect. Now the disadvantage is that there is an external scar. Those people who have keloidal tendency, they are contraindicated for these procedures. Now an alternative to this is, rather than having a submandible, you can offer a post-ramal incision which will give a scar, but it will be minimal. Now the more modification or a better version of that is an intraoral vertical ramus osteotomy. This will take care of the scar that was done, can happen because of the previous procedure. Now indication is, in this case you could do mandibular advancement as well as setback, both. Now in this procedure you will give an intraoral incision. Your intraoral incision will be more or less similar to the third molar incision. Okay, you can start from the first molar along the external oblique ridge, then go to the anterior part of the ramus. Okay, then do a subperiosteal dissection, strip the pterygomastoid sling, complete subperiosteal dissection, expose the sigmoid notch, do medial dissection, lateral dissection. Okay, once you have exposed the sigmoid notch, your vertical cut start from the sigmoid notch to inferiorly downward. A modification of IVRO is an L-shape osteotomy. Okay, that is, rather than starting from the sigmoid, you will be 2 mm below the sigmoid or 2 mm above from the lingula. You will make an horizontal cut just posterior to the lingula. You will stop, and then you make a vertical cut from that to the angle, inferior border of the mandible, just anterior to the angle. Once you have done this, you can either do anterior mobilization or you can do a setback. Once you have done that, put a splint, put the teeth in the splint, do IMF fixation, and then you do the plating of your osteomite segment. Close the wound in layer and put a pressure dressing. Now, we come to the bilateral split sagittal osteotomy, which is the workhorse of the orthognathic surgery. It's a very versatile procedure. In this procedure, you not only advance the mandible, you can do a setback. You could also correct the asymmetrical mandible. You can also do asymmetrical setback and advancement at the same time. Very versatile procedure. And then when you're doing advancement, you don't have to augment, because there is bone that is sliding over a bone. So there is no donor side mobility. You don't require a donor side for an extra bone. The bone is already available. So what do you do in this procedure is that, okay, you will do this is also done through an intraoral approach. You will put a bite block on the other side. Now, before I go on to the detail of the procedure, there are certain modification of the osteotomy cut that you need to know. Wexler was the first one who proposed the bilateral split sagittal osteotomy, but he initially gave only a horizontal cut, okay, involving both the buccal and lingual cortex on the ramus. Now, this was modified by Dalpon. Along with the horizontal cut, he also gave a vertical cut on the buccal, okay, on the you can say buccal cortex between the first and second molar region. So there was a horizontal cut, which was later on converted into a horizontal and a vertical cut. And you split the mandible, or you can split the ramus into a proximal and a distal segment. Alright, then Hansak further modified this. What he said that, rather than taking a complete horizontal cut, just restrict your cut just distal to your lingula and do not go ahead of the lingula. Then Epker further modified this. He advocated to minimal stripping of the muscles so that you preserve the vascular supply. So these are the variation that took place. Now what we're going to do is the latest variation that we use is the Epker's modification. Okay, you put a bite block on the opposite side. Then you give your intraoral incision, which is similar to your third molar incision, starting from the first molar region. Okay, but rather than giving a clavicular incision, you will leave a sleeve of attached gingiva on the tooth. Okay, you will give that along the external oblique ridge and to the anterior border of the ramus. You will do a mucoperiosteal dissection, export the coronoid ridge, anterior border of the ramus, inferior border of the mandible, okay, and the medial aspect. Okay, now as you go superiorly, you will try to resect, you can say dissect through the tendon of the temporalis, and you will put a Cocker's clamp on top of it. Okay, you hold the coronoid process so that the ramus become more visible to you. The soft tissues are separated. You'll do a medial dissection till you identify the lingula. Once you get the lingula, you will see the neurovascular bundle entering into the inferior alveolar canal. Then you will first put your horizontal medial cut. Okay, you will start from 2 mm above the lingula, just distal to the lingula, and come to the anterior ramus. Okay, then you'll go along the anterior border of the ramus, come to the buccal aspect, and depending upon how much amount of advancement and setback you want, you can extend the cut on the buccal cortical plate. Okay, between the first and the second molar, there you will stop your cut, and then you will give a vertical cut from that point to the inferior border of the mandible. Okay. Now initially your cut, when you're doing your medial cut, will be just on the lingual aspect, that is the lingual cortical plate. Then your cut will be between the lingual and buccal cortical plate. When you are coming to the body of the mandible, that is when you're giving your vertical cut between the first and the second molar, that will also be on the buccal cortex. But as you come to the inferior border of the mandible, that cut will be both the buccal as well as in lingual cortex. Once you have given your cut, join the cut. Use an osteotome to separate it. Okay. Once this portion is done, you will go on to the other side. Repeat the same procedure. Once that is done, you will take a spreader and try to spread or separate the segment. So here you will have 3 segments. The 1 distal segment and 2 proximal segment. Your distal segment will have all your dentition and your neurovascular bundle, and your proximal segment will be your condyle on both the sides. But what happens if your cut is not proper? If your neurovascular bundle come in the proximal segment, what you will do it? You will gently replace it into the distal segment, because you want these 2 bones to slide over each other. Alright? So once you have done this, then depending upon the requirement, whether it is advancement or setback, you could mobilize your distal fragment. Then put a final splint on the maxilla and put your dentition in that splint and do maxillomandibular fixation. Once you have done this, then you could plate your proximal segment with your distal segment. Keep in mind that the condyle should always be seated in a proper position. Check the placement of the condyle when you're doing this. You could put either screws or you could put a mini plate at the inferior border on both the sides. Then you will close the bone in layers and put a pressure dressing. Now let's move on to the maxillary osteotomy procedures. Now maxillary osteotomy procedure consists of segmental maxillary osteotomy, that is anterior maxillary osteotomy, posterior maxillary osteotomy, and a total maxillary surgery, that is Le Fort 1 osteotomy. Now Le Fort 1 osteotomy, you could either do a superior position of the maxilla, inferior position of the maxilla, advance it or set back it, or correct its cant. Alright, then the anterior maxillary osteotomy procedure. In Wunder's technique of anterior maxillary osteotomy, you will give a vestibular incision on both the sides in the premolar region. And then you will do a subperiosteal dissection, expose the piriform area and try to reflect the nasal mucosa from it. You could also give a midline incision so that you could expose the anterior nasal spine and visualize the buccal septum. Then Wunder also advocated giving a transverse palatal incision. Now this incision should be anterior to your osteotomy cut. Okay, try to undermine the area to have a better visualization. Once you have done a proper mucoperiosteal reflection, you will start your osteotomy. Your osteotomy will start from the piriform area to the extraction socket on both the sides, and then you will join this cut palatally through your palatal incision. Once you have done this, you will fracture it now and put a splint in the mandible, put the teeth in the proper position and fix it. Then Washburn modified this technique. He said rather than giving a complete transverse incision, just give a midline vertical incision and just try to undermine the palatal mucosa so that you preserve the vascular supply. You are not cutting through the vascular supply. Okay, so just a central nick is sufficient on the palate. You undermine that area and the rest of the procedure is same. Give the buccal cut. Now, the advantage of this technique is that it is simple and versatile procedure, provide direct access to the nasal crest and the nasal septum, prevent buckling of the nasal septum. Okay, it permit removal of unnecessary mid-palatine bone if it is present, provide an excellent vascular pedicle because you are not cutting through the transversely through the palate, you are preserving the greater palatine vasculature. Then it completely preserves the palatine vasculature. Now, let's move on to Lefort 1 osteotomy. Now, this slide shows you a diagrammatic presentation of the marking of Lefort 1 osteotomy. Here, a marking is done in the mucogingival junction, okay, from the molar to the molar region. Now, most of the time, some people also give a releasing incision in the upward direction on both the sides, and they give a V-shaped incision in the philtrum area. They say this philtrum area incision will prevent the loss of the vermilion depth, and the releasing incision distally will provide you more exposure. Now, once you have given your marking, then you will give your incision. You will expose the anterior wall of the maxilla, the lateral wall of the maxilla. You will try to expose the buttress area also. Try to expose from the posterior area, then piriform region. Then you will mark your osteotomy cut with a pencil. Once you have done your marking the level, now if you want to do a down fracture, that is it, or you want to do an advancement, a single cut is okay. But if you want to do a superior impaction, like in case of vertical maxillary access, you want to remove some amount of maxillary bone, you have to make two osteotomy cuts, superior and inferior. First you will make a superior inferior cut, then a superior cut. You will remove the chunk of bone and then you will do superior impaction of the maxilla. Okay, so depending upon that, your osteotomy cut is based on. So once you have done your marking, you will start with your osteotome. Either you could use burr or you could use a saw to do it. Okay, you will start on one side from the piriform area on one side. You will go posteriorly from the piriform area on both the sides. Once you have done your osteotomy cut, you will take an osteotome. Okay, you will take an osteotome. First, you will separate the anterior nasal spine. Okay, then you will separate the middle wall of the sinus and then the lateral wall of the sinus. Once that is done, you will use a pterygoid osteotome to do a pterygomaxillary disjunction. Now, when you're doing a pterygomaxillary disjunction, your pterygoid osteotome should be at an angle of 45 degrees and downwards. Okay, and then you should put a finger or ask your assistant to put a finger in the buttress region intraorally. So you could feel the amount when you're trying to tap and do a disjunction. Now, a modification of this is used wherein you do a down fracture, now rather than through the pterygoid but through the third molar extraction socket. Now, these can be done in most of the cases, but when you're doing orthognathic surgery for a cleft patient, you have to do a pterygomaxillary disjunction because the amount of scarring, the relapse chances are less. Okay. Now, and a better option for cleft patient would be a distraction rather than orthognathic surgery. But depending upon the case and need and requirement of the advancement, you will select your procedure. Now, once you have done the down fracture, okay, once you think that you have completed all the osteotomy cut, the septal, you can say the septum osteotomy cut, the middle wall of the maxilla, the lateral wall of the maxillary sinus, once you have done that, and then you do down fracture. When you're doing down fracture of the maxilla, you will take row disimpaction forceps. You will insert it inside the nose and onto the palate and apply a lot of force in the downward direction. Once you have done the downward fracture, you will mobilize the maxilla anteriorly in all round directions so that complete mobility is achieved. Then you will see if there is any kind of perforation or tear in the maxillary sinus lining. If it is there, you repair it. And then eventually you first put the maxilla. Initially you have already put a splint on the mandible. You will put this maxilla, put a final splint on the mandible, put the maxillary teeth on these splint and then try to reposition the mandible in whatever position you want, either anteriorly, posteriorly, whether you want an advancement or a setback. Once you have done that, check the occlusion, it is fitting properly, and then you fix the maxilla. Now, when you're fixing the maxilla, you have to put the plate in your buttress area. That is the piriform area. Then you have the zygomatic buttress area. So 4 plates you can place. Either you could use an X-shaped plate or a Y-shaped plate, and screws on either side of your osteotomy segment. Close the wound-in layer. Some people also advocate use of VY closure in the anterior frenum area so that the vestibular depth is not affected. Now this is how the plate looks like once you have done the plating of the osteotomy. And then this is one of the case wherein the patient has severe class 3 profile. Patient is actually in horizontal grower. If you could see, this is the occlusion before the orthodontics. The canine are labally placed. You need to align the arch also. Preoperative radiographs, lateral ceph and OPG. In lateral ceph, you can appreciate the patient is a horizontal grower. There is maxillary hypoplasia as well as mandibular prognathism. So here we have to do bi-jaw surgery, that is maxillary advancement and mandibular setback. Now this is the patient profile after completion of orthodontics. This is the occlusion that you achieve after completion of orthodontics. You can see the arch is beautifully aligned, the canines are in position. The premolar was extracted depending upon the requirement. This is how the profile is after orthodontic treatment. And then this is how we got the occlusion after orthognathic surgery, that is maxillary advancement and mandibular setback. You could appreciate the profile. This is just 4 days post-operatively because of lot of swelling. Now as the swelling will decrease, you could see the jaw has moved considerably behind and the maxilla has come ahead. This is the post-operative photograph, lateral ceph and OPG. You can appreciate the placement of the plate and the osteotomy sites also. With this, I would like to conclude by saying that the success of orthognathic surgery, there are a number of points that you need to keep in mind. One is, what does the patient want? You should always ask what is the demand of the patient. At the same time, you should tell the patient what you can provide so that both of you can come to a consensus. Then a detailed treatment planning is a must in this case. And as I mentioned earlier, it is always a collaboration between an orthodontist and an oral and maxillofacial surgeon.